Hello and welcome all. This video is based on the latest 2025 ESICM consensus guidelines for managing very old patients in intensive care units. Developed through expert consensus across critical care, geriatrics, and emergency medicine, these guidelines help us move beyond just age and focus on personalized, respectful, and meaningful ICU care for the elderly. Principles of ICU care for very old patients. That is more than 80 years, chronological age alone should not decide ICU admission or treatment. Always assess frailty, functional status, cognitive status, and multimorbidity. Patients' own preferences about acceptable quality of life should guide decisions. Discussions on goals of care should include patient, family before ICU admission if possible. Limitations of life-sustaining treatment should consider expected quality of life, not just survival. Regular re-evaluation of treatment goals during ICU stay is necessary. ICU care should be individualized based on acute and chronic conditions. ICU admission recommendations. Collect baseline information on reason for ICU admission. Functional independence. Frailty, by clinical frailty scale. Cognitive impairments, like dementia. Previous hospitalizations or ICU admissions. Nutritional status. Sensory impairments, hearing, vision. Advance directives, if available, should be obtained early. In uncertain cases, consider a time-limited trial of intensive care after discussion with patient, family. ICU management recommendations. Prevent and actively manage delirium. Tailor sedation, ventilation, cardiovascular support, and nutrition to aging-related physiological changes. Prefer non-invasive ventilation or high-flow oxygen when appropriate, based on baseline function. Early mobilization must be initiated. Medication review should be performed during ICU stay or at ICU transfer. Family meetings should be arranged to align treatment with patient wishes. Plans for treatment escalation or limitation should be documented and reviewed regularly. Transfer from ICU and aftercare. Before transfer, check functional status, cognition, communication, nutrition, mobility, skin, ongoing issues, medication plan, and goals of care. Plan early transfer to a geriatric rehabilitation unit if available. Geriatric assessment should continue even after ICU discharge. Always communicate clearly with the next team, especially primary care. Infrastructure and team support. ICU teams should involve physiotherapists, dietitians, speech therapists, pharmacists, and social workers. Long-term patient outcomes should be tracked and used for continuous improvement.